Cory Calendine, thank you so much for the introduction. You may be wondering, why am I here? I mean, we just heard from Doug, who owns and controls Monogram. We've heard from, the Waz we're going to hear from a little bit later. Barad owns a multi-million-dollar VR company. I don't know why I'm here. I wanted to share that with you and hopefully establish a rapport with the audience today. Now I'm going to talk to you very pragmatically about where we are in robotics today and how I think it has a massive role in the anterior world. And based on some earlier questions around, that were asked to Dr. Murphy, I intend to be obliterated at the end. So please feel free to make your way to the mic and share your thoughts. So humans augmented, I really think that is it for robotics, is we have to understand that we're still the human and we're still going to be in control on some level, and how do robots interface with us to make us better, not necessarily take over a job but make us better. These are my disclosures. I'm a consultant for Stryker and Avail Med Systems, a procedural telemedicine company, and I work with OSO as well that I mentioned earlier. So it's interesting that we're all talking about robotics, and actually 4 times today people have already said robotics is where we're going, or they've used some version of it's where we are. And yet I don't think we really know what a robot is. We have no agreed upon definition. It was actually Da Vinci in 1495 that said that made the first robotic system. Essentially it could shake a hand and extend a gentleman a drink and lift his visor. Pretty impressive, I guess, for 1495. But maybe that's what you think about. Maybe you think about Asimo, who can play soccer and all those great things. Or maybe you think of something very futuristic, like we're starting to see from Tesla, iRobot and Will Smith, if we can still mention his name. But the reality is we don't really have a definition about what robotics is. And I'd like to share with you my no doubt biased, no doubt somewhat influenced by my current practice, but what I like to describe is the 3 pillars of robotics. And I think there's a real opportunity here to take these 3 pillars and be able to classify the robotic systems that are now available. So this is it for me in a very pragmatic, very small word explanation. First, you have to start with the truth to be a robotic system in my world. At least again, we can categorize the current systems in this fashion to study which of these 3 elements are so critical. So you start with the truth, you predict the future, and finally, of course, necessary, you have to perfect the execution. Because the reality is you may have the truth, you may have the perfect plan. If you can't execute it, like Doug was talking about, if you can't actually deliver that high level of accuracy that Stefan was trying to reference earlier, then it really doesn't matter. So you really have to have 3 pillars, in my opinion. I always ask the question, have you ever seen a 3-legged table wobble? The great David. The reality is a 3-legged table can't wobble because between any 3 points there's a single plane. It's literally the only thing I remember about geometry class. So let's start with the first. Start with the truth. Now, obviously what I'm suggesting here is that we start with objective 3-dimensional anatomy. You've heard us talk a lot about AR today and look at surface anatomy. You've heard a lot about fluoro and it being a 2D image. You have to start with the truth, I think, in my opinion, in order to be leveraged or categorized like this of starting with the truth. And for me, in the Mako world, that's obviously a CT scan. Obviously, Monogram's leveraging that, and several others are as well. You get not only surface anatomy, but you get subsurface anatomy. And we know it's right? We know X-rays can fool us. You look at that picture on the far left of your screen and you say, oh, that's a pretty good looking X-ray. Everything looks good. Beam looks centered. Obviously, a little bit of arthritis on the right. But I included these 2 images down here on the bottom right with the cup in, just so you can see how dramatic the difference of cup position. That cup hasn't moved from image to image, but the image I'm getting is very different. And it's very different for a lot of reasons. Where the beam hits it, the angle. This is a standing film. This is a supine film. Obviously, where the pelvis is in 3-dimensional space. That cup looks like it's moved dramatically from one to the other. It actually hasn't moved at all. So we know X-rays are good, but we also know that our ability to evaluate those X-rays can at times be challenged. And there's a lot of tech around. How can we get better at interpreting X-rays? And I applaud the work in that space because so many of us use C-arm. But the reality is X-rays are only as good as you understand them. And they're always going to be 2-dimensional. I wanted to show this 3-dimensional comparison. So this is within the software. This is a CT scan turned into a 3D model. Obviously, that makes a lot of sense for us. You can see there They're pointing there on the video that this is a 42-20 cup position. You may ask, why did I pick 42? And I would tell you, because I can. And so here's the reaming view. It's the green bone that we're going to take away here. You can see the CT scan in multiple planes. Obviously, you want to take away the bone. You want to ream. This is all preoperatively now based on the CT scan. So you want to, again, start with the truth. One more here on the femoral side now. You know, the cup gets a lot of respect. Obviously, we want perfect cup position. We want perfect leg length and offset. But what can we learn more on the femoral side? Obviously, we know everything, and this is an older model of the software, but it's showing us femoral version, how the stem sits in there, and the angular reconstruction there. And then ultimately, this isn't an X-ray. This is the CT scan turned into an X-ray, and this is all preoperatively because it's what we're using, what we're used to looking at. Excuse me. So what about the application of preoperative planning, starting with the truth in complex cases? I'll show you just a couple of examples. I meant to start a timer. Feel free to hook me at any point. Okay, so complex cases, a Perthes disease case, it's not horrible, but nonetheless, this is what the CT scan looks. That doesn't really help me too much. That may be what you would get with your X-ray, but these are very valuable. What bone am I taking away? Where's the cup going to sit? Here in these images, the green is the cup, of course. And then how big anterior, posterior? How big proximal to distal? What's the right fit? And do I really want to move the hip center? So you can see here that I'm moving the hip center from the native, which is the magenta, I think is on label to say. I would call it pink. And then the green is the reconstructed hip center. So I'm moving it 6 millimeters superior and 7 millimeters medially. And I hope somebody comes to the mic and complains about that position. But I would tell you the only reason why you're able to complain is because I told you. I'm 6 millimeters and 7 millimeters. So the fact that we can have that power of a surgeon to dictate our plan, obviously the reaming view again. This is what the cup looks like in place. How much bone's overhanging? How much contact to the cup am I getting? And then obviously as anterior surgeons, we want to know, is that lip inside the bone? C-arm's never going to tell us this until the cup is down. And then we all do the same thing. We all either look in there and stick our finger in there, and guess what? The cup's always just inside that anterior rim. Of course it is, because we don't want to move the cup at that point. But what if you knew before you put the cup in? Femoral planning, same thing. This is in three-dimensional. What does that stem look like when it goes into the bone? And what's my version? And what's the interplay here? Here, this is a Perthes case, 26 degrees of anteversion on the femoral side. This may be a case, I may not use a collared stem. I may cement. I know. And you got to be ready for that, because that's obviously not a routine from the front. But what about a complex case with hardware in place? What if preoperatively, I could tell you whether to go anterior, posterior, and what kind of pains you would have, whether or not you picked one over the other. This is the same kind of thing, right? Three-dimensional imaging. I know where the screws are. You can see them very clearly. I knew in this case I was going to burr, using a Midas Rex type device. I'm going to burr down that screw. It's actually the fourth screw in the plate, and I'm going to single-stage ream, and I'm going to put the cup in. I know all that preoperatively. I know my version. I know there's a lot of bone anterior if I go anterior, but I also know I don't have to go posterior. Bada bing, bada boom. It turns a complex case into a simple case. So number one, first pillar, start with the truth, three-dimensional imaging, and I've shared with you the value that can have. But the second is predict the future. And this means different things for obviously different procedures. When I talk about the knee side, it's going to mean something around balance and pressure. And I'd love to talk with Doug later. He probably won't talk to me, but I'd love to talk to Doug later about where I think we can go with knees in the robotic space. But predict the future in hips is a lot around this impingement concept and dislocation. We've already heard today from Dr. Mott. I have such great respect. I wonder how many people have scrubbed with Mott. I'll bet it's most of us, but scrubbing in with him is an incredible experience. He's a master surgeon, and he described from the mic today a 1 in 1,000 dislocation rate, which is absolutely true in his hands, and others have showed similar, but that is not what's going on in reality in the real world because of some of these interpretation of x-rays. So anterior approach does not dislocate. I know it's easy to say that, but obviously we know it does. And there's a ton of literature around this. We know the Lewinick safe zone is not helpful for us largely, that 58% of the hips that dislocate are actually within that safe zone. Part of that is the cup side, and part of that is our lack of understanding of the femoral side. It was actually Larry Dorr in 2007. It's a great paper in JBJS that talks about impingement, and it's the interplay between the component position and bony implant and soft tissue impingement. He talked about 75% of the impingement is actually bony impingement, so it's not all about the implants. And then obviously we all love to talk about hip-spine relationship. And even if you think that as an anterior approach, you're getting some protection, and by the way, I think you do, if you read the Utah data, Jeremy Gilliland and several others showed that still with the anterior approach, people with a fused or stiff spine do have a higher rate of dislocation. For them, it was a 4x multiplier. So it's really around this, and this is a simplified understanding of hip spine. I make no attempt to exhaust this conversation today, but essentially if you're standing and you go to sit, now this is the far right image, which is normal, the pelvis is supposed to obviously extend, the cup obviously changes position and covers posteriorly to prevent posterior dislocation. The middle picture is a stiff spine, so you're standing, you go to sit, and the pelvis doesn't move. Therefore, the cup hasn't moved, and it leaves that head uncovered. This is the most crude, most simple way to explain hip spine that I could come up with. Essentially, you want the pelvis to rotate back to move the cup in a different position and protect you when you're sitting. So this is what normal spine films look at, but a lot of us don't want to take films, and we struggle to interpret what we're looking at. But what if we could take that information very simply, apply it not only just to hip-spine relationship, but also this concept of impingement, and I could prescriptively give you the plan. I could predict the future of who is going to impinge and who is going to dislocate. Again, these are x-rays of a stiff spine. You can see sacral slope is the red line, standing, sitting, no change. That could be a problem. So within these robotic platforms, again, start with the truth. Number two, predict the future. You can actually put the dynamic motion of the pelvis in and then go through a virtual range of motion and know whether or not you're going to impinge. So you simply add the data, standing sacral slope, sitting sacral slope, and you can see where they're impinging. This is the same image. It's just I've left the femur on the left side to illustrate and I've taken it away. The red indicates impingement. So this patient is impinging not only on the liner, this is already a 40 head ball, but also on the AIIS. I doubt we're going to take down that bone, but we could increase offset, etc. Again, a better plan. Not thinking in the operating room, but coming in with a better plan. Now that will build efficiency. Same thing in extension now, 90 and 50, you can see the impingement on the liner. So this is a short video here that illustrates that, and I think it'll make a better point. I wish I could speed this up a little bit because it is a little bit of a longer video. But a seated position, sacral slope 14 degrees, standing 32. So again, standing 32, they sit down, their pelvis rolls back, it decreases their sacral slope. So all you do is you have the CT data because you started with the truth. You put this data into the computer system. You can see it's changing. Now, supine to standing in this patient is about the same as far as the reference of the anterior pelvic plane. It's not that average 5 or 6 degrees. How many of y'all just automatically angle the C-arm 5 or 6 degrees and say you're good? The anterior pelvic plane, it's the most common, but it can be widely varied. But here, when they sit, you can see these cup numbers. This is the relative cup position, the seated position. Again, it's a concept of where the cup is in three-dimensional space, and it can give you a headache if you think about it too long. But what does the impingement look like? So now for this individual patient with that information, you can take the hip through a range of motion. Obviously you can leave it in extension and external rotation. And again, what I'm going to do here is take off the femur so that you can see the impingement. We can argue about these numbers too. You know, what range of motion do you want? When I'm in the operating room on the HANA table, I drop the leg 30 degrees of extension, external rotate it 7 degrees or so I say. If I'm doing it manually, I want to make sure it doesn't lever out or lift out. Here you can actually get an actual number, 5 degrees in extension. I think at 55 it impinges. There you see the impingement. And you can decide what you want to do about that. Dual mobility, add length, add offset. It's not dictating to you a plan. It's giving you better information so you can make a better decision preoperatively instead of intraoperatively, oh, now what am I going to do? So the third pillar, a little bit more quickly now, perfecting the execution. The reality is there are multiple published data that shows that robotics, if you control the whole platform, meaning start with the truth, predict the future, and perfect the execution, that you're more accurate. This is only one study. This is Dom's study, which clearly shows, I know that says posterior on there. I apologize. It should be blacked out. I don't want to offend anybody in the audience. But you can see the accuracy of robotics versus some of these other techniques, inclusive of the middle view, which is fluoroscopic anterior. Why is it not more accurate? Because we have difficulty interpreting the x-rays, and it's 2 dimensions, not 3 dimensions. This is a poster. HSS guys, you know, they're still doing posterior approach. And so they really love this accuracy piece, trying to address dislocation in particular. I think impingement, patient satisfaction, greater return to high level activity. If we can control the range of motion and get their soft tissue right, I think that's what we're going to see. You can set up this in the OR any way you want. This is me in the operating room. The eye, if you will, the camera's down at the foot of the bed, but you can really move it anywhere in the room that you want. These are just several various setups. I wish I had more time. But essentially, pragmatically now, you put a single array in the pelvis. You then put the array, you use that array in 3-dimensional space to register the bone. Again, we're marrying the preoperative CT scan to what we see intraoperatively. That way, we have a full system from start to finish, kind of what Stefan was mentioning earlier. We want to make sure that what we find in the operating room really is truth. That was one of the problems with navigation, wasn't it? That garbage in, garbage out. If you're not lining up with a CT scan, it won't let you proceed. Once you validate your plan, ultimately, you're going to ream the acetabulum, and ultimately you're going to put the cup in. And you're going to put the cup in with the robotic arm exactly, and I think the window's going to pop up here in a second, exactly, I think you wanted 42 and 13 in this patient. So when you ream, it allows you to ream within a haptic funnel, but when you put the cup in, you want to go exactly to your plan for all those reasons that we've already talked about. There it is, 43 and 17 is where he ultimately wanted to go. It'll show you depth, and obviously you can still check intraoperatively, check your leg length and offset. There may be reasons why you want to lengthen them or increase their offset. All of that is in the control of the surgeon. So the 3 pillars of robotics, again, how I understand robotics, but also I think valuable thought process for all of you younger surgeons to evaluate future technologies around these 3 pillars. And I think it gives us a structure in order to evaluate the literature that's going to come out around robotics. But what's next? What's next? If you can control from the beginning to the end and you can objectively control some of these numbers, what's next? Well, I don't think we're done on the implant side. And so I think we can have better tools to implant. You heard Doug talk about customization of implants. That's actually not very hard once you control the whole platform in the robotic space and have an arm that can objectively prepare your bone. It's actually not a hard jump. We can do that whenever we want. There may be some benefits. There may be other areas that we can grow in. But if we're going to customize, if we're going to mess with efficiency, we got to be able to produce that very quickly. I don't have a 3D printer at my hospital yet, but maybe someday. And then what about computer vision? You know, I talked about standing and sitting, which is a really simple way to illustrate where the pelvis is in 3-dimensional space. But I bet you're thinking, I don't want to send them back to x-ray. You don't know what my techs are like. What if we could just put a camera on them and with computer vision actually know 3-dimensionally where their pelvis is in space and these activities of daily living that they want to get back to? What if we could assess it without the other x-rays? What if we could assess it just by holding an iPhone? Actually, we can. This is open source software that anybody can look at. And then we talked a lot about, I shouldn't be talking about VR and AR. We heard complete champions today talking about those platforms, and I applaud their good work. But how does it integrate with the CT scan? Can you pre-plan that exact patient in the virtual world so that everybody's ready for the case? Actually, you can. Now, remote surgery, you probably saw this video on the internet. Like, this guy is in London, and he's operating on a banana in California over a 5G network. I don't know why you want to do that. But remote surgery can certainly happen, but it's really around sensors, better data. These are just 2 examples. But Daniel Kraft is actually in this space, and I was at Doc SF, and he had this quote: "We don't want data," and I'm talking to industry now. "We don't want data, we want the insights." And that is where this idea of augmented intelligence, so artificial intelligence, really augmented intelligence, giving us better tools in order to dig through all the data. That's the key for us today. So thank you so much.